when patient is associated with altered level of mentation within the 8 week of onset of the illness, we call it an acute hepatic failure. Chronic hepatitis is the inflammation of the liver which lasts for at least 6 months. Cirrhosis is basically a replacement of the classical liver architecture with fibrosis, scar tissue, and regenerative nodules. Permanent hepatitis is the severe impairment of the hepatic function or severe necrosis of hepatocytes in the absence of pre-existing liver disease. Target of hepatic viruses are hepatocytes. Hepatocytes uptake involves a receptor on the plasma membrane of the cell. When the virus is within the cell, the viral RNA is uncoated and a host ribosome binds it to form polymers. And hence the synthesis of a viral protein is being started. Then these genomes are copied by a viral RNA polymerase. Minimum cellular morphologic changes result from hepatocyte infections. There could be a mild lymphocytic infiltration with a varying degree of necrosis within the cell. This is the diagram which is showing that the receptor, the virus has bound, and it has gone within the cell. It has released the encoding of the RNA, then translocation and the proteolytic processes leading to the RNA replication, and after the replication they are assembled and released as mature viruses. Whenever there is an infection, usually there is a phase in which the virus replicates. This is the time during which most of the time the patients are asymptomatic. Then there is a prodromal phase, after which the patient becomes symptomatic, develop yellowish discoloration of the sclera and skin, and the patient then proceeds with a variable time period into a convalescent phase where the symptoms and the jaundice gets resolved, and slowly and gradually the liver enzymes returns to normal. Patients usually experience anorexia, nausea, vomiting, altered taste, maybe some joint pains, malaise, fatigue, a low-grade fever, pruritus. This is usually seen in the early days when the patient hasn't developed jaundice. Some of the smokers may develop an aversion to the smoke. During this phase, usually they are suspected as a case of flu or mild food poisoning or gastroenteritis. Later on, after some time, the patient will develop jaundice, and then they will start passing dark color urine, maybe pale color stool. There could be gastrointestinal symptoms, malaise. They usually develop anorexia, and then there is a tenderness and pain in the abdomen. Vomiting and nausea is usually present in these patients. Severe cases may result in permanent hepatitis. Whenever the patient develops altered level of consciousness, goes into the hepatic encephalopathy, sometimes with the renal manifestations and bleeding diathesis. And this is something very serious when the patient develops and have got a variable mortality depending upon the management. Most of the patients who have got hepatitis A, hepatitis E, they usually do not progress to a chronic state. Most of the patients who have developed hepatitis C, they can go into a chronic state. Most of the patients who have developed hepatitis B, they usually clean the disease, and only 15 to 20% they progress to the chronic hepatitis. Some of them who have developed chronic hepatitis will remain asymptomatic. They have mild symptoms, and they can present later on with the complications like portal hypertension, cirrhosis, upper GI bleed, hepatocellular carcinoma. Whenever we are examining these patients, they have got low-grade fever, vomiting and anorexia is there, which leads to dehydration, and the patient are usually having tachycardia with dry mucous membrane, loss of skin turgor, and delayed capillary fill. During jaundice or icteric phase, there is a yellowish discoloration of the sclera and the mucous membrane. The skin may be jaundiced in a severe condition, and they can have urticarial rashes. When we do a abdominal examination in these patients, hepatosplenomegaly may be there. Usually the liver is diffusely enlarged and tender. In imaging studies, ultrasonography is the mainly and easily done investigation with the objective to confirm the findings of hepatic inflammation and to rule out other causes like liver abscess, cholecystitis, or some other biliary diseases. Liver biopsy is not usually done in patients of acute hepatitis. It is done only in some specialized centers with the specific intention. As far as per routine, liver biopsy is not indicated in patients who have got acute hepatitis. However, in those studies in which the liver biopsy has been done, it has shown that there is a lymphocyte infiltration, there is a moderate degree of inflammation and necrosis. Portal or bridging fibrosis sometimes seen, sometimes regenerative nodules are also seen in those patients who are having an acute exacerbation in the background of a chronic liver disease. This is just a histopathological picture. You can see there are lymphocytes around apoptotic hepatocytes, and there are clustered hepatocytes with balloon degeneration. This is because of the damage to these hepatocytes by the virus. What are the investigations? Usually we do the liver function test. Elevation of the serum transaminase is not diagnostic, but is very useful. It helps clinician to make a diagnosis that there is something inflammatory going on in the liver. In acute hepatitis, it's the ALT which is elevated more than any other enzyme, and sometimes its levels are more than 1000. In chronic hepatitis C, ALT levels are usually less than 1000. Classically, they are between 200 to 600 range. When we do the urine analysis, there will be bilirubin. The blood serum bilirubin level will be elevated. Alkaline phosphatase is elevated, especially if there is an intrahepatic cholestasis. It is also elevated in cases of liver abscess and biliary obstruction. Synthetic function of the liver, prothrombin time, is an important marker of any inflammatory condition of the liver because it tells us about the acute status of the liver synthetic functions. Blood urea nitrogen and serum creatinine, they are important investigations so that we should be careful about hepatorenal syndrome. Serum ammonia in patients with altered mental status and other evidence of hepatic encephalopathy. Yes, CBC has to be done in all those patients who are presented to a physician. There could be differentials whenever the symptoms which have been described is presented. Commonly is the cholecystitis, cholangitis, pancreatitis, and sometime in gastritis. But there could be other possibilities as well. Now let's come to what hepatitis A. Hepatitis basically is caused by 5 hepatotropic viruses, A, B, C, D, and E. Hepatitis can also be caused by drugs and toxins. Most of the time, the clinical manifestation, whatever the insulting agent is, are more or less the same clinical manifestations. Hepatitis virus is a small 27 nanometer RNA hepatovirus. It is single-stranded, positive senses, linear RNA enterovirus. Its main route of transmission is fecal-oral. Its incubation period averages around 30 days. Uh, ALT and AST levels, they are usually returns to normal within 5 to 20 weeks. Interestingly, patients before developing clinical illness may be passing virus in their stool for at least 2 weeks. Hepatitis A vaccine was discovered in 1995, and since then its incidence globally has decreased markedly, but it is still common in those societies where the hygienic conditions are not satisfactory, especially in a crowded or low socioeconomic setups. Those people who are visiting countries with high prevalence of hepatitis, from those countries in which the hepatitis A is not a common disease, are advised to get vaccination. They can also get a passive immunoglobulin if they are being exposed. The disease is mild, self-limiting, does not cause a chronic course, and the treatment is supportive. Rehydration is important, and caloric intake is important in these patients, because if a patient is having a lot of vomiting, then there is a possibility that they can get dehydration. Serology is an important tool of diagnosing hepatitis A virus. Immunoglobulins, both M and G. While the M is usually present in the early stage of the disease, it remains positive for 3 to 6 months, and it highlights that patient has got a recent infection. Immunoglobulin G against hepatitis A virus appears when the IgM has disappeared, and then it persists for many years. This diagram showing the time course of the infection, you can see from up to 2 weeks the patient is in an incubation period, and then they start prodromal state. They start in passing feces, virus in their feces, and the liver enzymes are elevated, similarly immunoglobulins, and then after some time, that is after a patient has got 6 to 8 weeks, they started having immunoglobulin G and they develop immunity. Now another RNA virus is hepatitis C virus. It's a single-stranded RNA virus, flavivirus genus, and it is enveloped. It has got 6 genotypes with numerous subtypes. Globally, the major genotype is the genotype 1, which is present up to 40 to 80% according to different studies. In Pakistan, the most common genotype is genotype 3. Its incubation period is 7 to 8 weeks, and there are at least 170 million infected people worldwide. Acute hepatitis is very rare with hepatitis C. Usually these patients, they do not develop severe jaundice, just mild fever, malaise, and flu-like symptoms. So most of the time, acute stage of this virus is ignored and not being diagnosed. Most of the cases are diagnosed when they are in chronic state. It is quite common in Pakistan, in India, in Bangladesh, in Afghanistan. The route of transmission is parenteral, especially the blood transfusion and blood products which are not being screened properly. Its emerging threat is among the IV drug abusers, tattooing, body piercing, hemodialysis. These are all important risk factors of transmission of this disease. Risk of sexual transmission and maternal to neonatal transmission is low in case of hepatitis C. As I have said earlier, it's usually a mild disease in acute stage, does not cause significant acute illness. And most of these patients, they will progress to the stage of chronic hepatitis. 20% of them are likely to develop cirrhosis, and The incubation period is 15 to 150 days with symptoms developing anywhere from 5 to 12 weeks after exposure. How hepatitis C is diagnosed? The common screening investigation is anti-hepatitis C antibody, which definitely not differentiates between acute and chronic, but after getting a positive result for antibodies against hepatitis C, a clinician can proceed further to investigate, like doing a polymerase chain reaction to detect the viral RNA and then proceed for the treatment. The treatment of hepatitis C as in acute stage we are not able to see the case, so the most of the treatment is directed towards the chronic hepatitis. Initially, there were interferon and ribavirin and pegylated interferon, which were used for years for the treatment of hepatitis C, chronic hepatitis C. The directly acting antiviral results are excellent, and up to 98% of viral clearance has been seen in patients. There are different types of medications which are available for the treatment of hepatitis C, such as protease inhibitors. You can identify them with the word previr at the end, and the common which is available, voxeloprevir and glyceraprevir are very commonly used in the word for the treatment of hepatitis C. Then we use 5S 5A NS5A nucleoside inhibitors. They are commonly used in Pakistan, and you can identify them with the word ending Asvir, ASVIR, and the drug which is easily available in Pakistan is declatasavir and vactasavir and ledeprasavir, which we are using in our patients regularly. Then NS5B inhibitors, and the drug which is available is sofosbuvir, and these are identified by the word BUVIR, Buvir at the end. So these are the three important drugs which are available for the management of chronic hepatitis C. Let's talk about another virus which is known as hepatitis E. It is a virus of genus Hepavirus. Its size is 27 to 34 nanometer. It's an RNA virus. It's the major cause of acute hepatitis in Asia, Middle East, and North Africa. Basically, it is transmitted fecal-oral route, and it's a self-limiting disease. The incubation period of hepatitis E virus is 2 to 9 weeks. Its case fatality rate is 4%. Most of the time, hepatitis E is a benign disease which, without any specific treatment, gets resolved. However, in pregnant ladies, this disease is associated with very high mortality. Up to 30% mortality has been reported in different studies in those patients who are pregnant and has developed hepatitis E. Hepatitis E antibodies, IgM, is the one which you usually do to identify an acute infection. AST, LAT, both are elevated. Hepatitis E characteristically have a prolonged history, and it takes 1 to 2 months to return to normal. It is associated with a stage of intrahepatic cholestasis, in which the patient can develop elevated alkaline phosphatase level as well. Now let's see. A case of 61-year-old female is brought to ER. She is drowsy and disoriented. Physical examination: abdomen is distended, non-tender, she is jaundiced. She has got a prescription for peginterferon and ribavirin. When she was asked to raise her hand, the examining physician noticed a coarse tremor. ALT is 93, AST is 89, total bill is 3.1, ammonia 124. So what is the most likely diagnosis? There are 5 options. Bleeding esophageal varices, no history of bleeding, so it's not there. Hepatic encephalopathy, patient is having drowsy, disorientation and tremor, so most probably yes. Hepatocellular carcinoma, there is no clue for the hepatocellular carcinoma. Similarly, hepatorenal syndrome and spontaneous bacterial peritonitis. So the diagnosis is hepatic encephalopathy. Let's talk about hepatitis B and theater. So hepatitis B is a 42 nanometer hepdanavirus. It is partially a double-stranded DNA genome. It has got an inner core protein and outer surface coat. So we measure a core antigen and a surface antigen in this patient. There are 8 different genotypes from A to H. 2 billion people worldwide have passed a present infection, and out of them, at least 400 million people are chronic carrier. It's a common cause of hepatocellular carcinoma. It's a common cause of death. It is important cause of liver transplant worldwide. The people who are at risk, apart from the healthcare providers, because we are being exposed to all these diseases, whether it is hepatitis or corona or tuberculosis or Congo. Being a health care provider, we are exposed to all these dangerous diseases. Among the community, IV drug abusers, patient suffering with hematological diseases, thalassemias, and bone marrow aplasias, needing blood transfusion, those people who have got sexual promiscuity, people in contact with hepatitis B virus carrier, people who are visiting areas of high prevalence, and healthcare provider. The main route of transmission is parenteral. IV drug abuser, needle sticks, hemodialysis. And sexually, it can be transmitted if it is unsafe sex. It can have got a vertical transmission from mother to the baby. Surface antigen is present in acute of chronic infections, both condition it will present, detectable in 1 to 2 weeks after infection. E antigen appears shortly after surface antigen. It is an indicator of replication and also an indicator of infectivity. Surface antibodies are present after vaccination or clearance of hepatitis B surface antigen. It indicates that the patient is immune, a person is immune to hepatitis B virus. Hepatitis B core antibody, sometimes it is the only serological marker during window period. Sometimes it could be a marker of a chronic liver disease in those patients who have got negative surface antigen, and when we do a core antibody, we come across that they have got this core antibody is positive. This is a graph or table which is showing how to interpret. So if IgM to hepatitis B core antibody is present and patient has having surface antigen, this is an acute infection. If patient has got surface antigen positive, it could be an acute infection. If patient is having core antibodies G positive with anti-surface antigen antibodies, maybe a resolved infection. If a person is having just antibodies against a surface antigen, most probably he is the one who has been virally vaccinated like most of us. If a patient has got G antibodies as well as a surface antigen, patient is having a chronic infection. This is a graphic presentation of how the disease progress from initial stages to incubation period. Then patient develops acute infection, may persist for from 2 weeks to 3 months, and then early recovery, and patient can go into chronic stage as well. Acute hepatitis B is when patient has got less than 6 months based on significant aminotransferase activity due to necroinflammatory injury. Symptoms are often non-specific. There may be myalgia, malaise, nausea, fatigue, pruritus, abdominal pain, right upper quadrant pain. Patient may be jaundiced, or they can present in a state of ferment hepatitis. Chronic hepatitis B is seen when there is the problem is greater than 6 months, and they usually it is based on the grade, stage, and etiology, fibrosis, and necroinflammatory processes. It can last for decades. Patient can remain in a stage of chronic hepatitis for years and years and without any symptoms. Immune tolerant stage when there is a high replication, but there is no evidence of necroinflammation as the liver enzymes are normal. There is very low fibrosis and very low inflammation. Immunoactive stage when there is a high level of liver enzymes with high level of hepatitis B virus DNA, E antigen, and there is a active replication going on. Carrier stage when there is a role replication, and when the term seroconversion is used when from hepatitis E antigen positive to hepatitis E antibody development. These are usually having carrier state with low hepatitis B virus levels. Most of the time liver enzymes are normal and they have got very low risk of developing hepatocellular carcinoma. Sometimes there are people who have got hepatitis B antigen negative. They may be having a high DNA, liver enzymes may be raised, and these are the patients who have we seen late phase of hepatitis B virus, and they can persist like it for years. Resolution means when there is a complete clearance of hepatitis B virus DNA from the plasma of the patient. Serology is important for diagnosing chronic hepatitis. Liver chemistry, AST, ALT, alkaline phosphatase, total bilirubin. You must appreciate all the hepatic insults. They more or less have got similar biochemical picture, and then it comes the clinical acumen to differentiate among the different agents. Hepatitis B virus DNA is a very accurate marker of viral DNA and is detected by polymerase chain reaction. Sometimes we go for a liver biopsy in cases of chronic hepatitis. This is a graph which is showing that in children, if they develop a hepatitis B infection in their childhood, whether it is through a vertical transmission, unfortunately 90% of them they develop chronic infections and then they can develop cirrhosis of liver. While in cases of adult, at least 80 to 85% and sometimes 95% of patients they clear the virus. It is 5 to 10% of the people who develop chronic hepatitis and then progress to the cirrhosis of liver. Incubation period varies between 30 to 180 days. Acute hepatitis B infection 90% resolves. Chronic hepatitis B infection 2 to 10% progress to chronic state. In children, we have said that 90% in children less than 5 progress to chronic state. Risk of cirrhosis 5-year accumulation risk of 8 to 20%, and then out of them 5 to 10% people progress to hepatocellular carcinoma. So this is basically the natural history of a chronic hepatitis, how they can develop chronic hepatitis. They can remain as a case of chronic hepatitis for years and years, and sometimes they die without being known as a case of chronic hepatitis. Some of them they develop cirrhosis and manifest with the clinical features of cirrhosis of liver, and some of them they can present directly with evidence of a hepatocellular carcinoma. In cases of chronic infection, the treatment is basically interferon was given to these patients, but nowadays we are not going to give them interferon. What we are giving them is lemivudine, we are giving them entecavir, and we are also using uh, tenofovir. We have got tenofovir fumarate, and then a latest one is the tenofovir alafenamide, which is just 25 milligrams. So these are the drugs which are used in case of chronic hepatitis, may be dealt when somebody is going to talk about chronic hepatitis. So this is all about chronic hepatitis. So I will just skip this table for chronic hepatitis, as the lecture will be taken separately. One thing which I want to tell you, that sometimes you get report in copies of hepatitis D virus DNA, and sometimes you get reports in international unit. So one international unit is equal to 5.6 copies. Just change it like this. This is an interesting diagram showing hepatitis B surface antigen test with negative. Do the antibody test. If it is positive, patient has developed immunity. If patient has not positive and negative, then you go and vaccinate them and give them three shots in 6 months. Our routine is 016, but sometimes we also give 013 as well. If it is positive, then screen for liver cancer, monitor for liver damage, and avoid those things which can damage the liver, especially alcohol. All those patients of hepatitis B, if they have got chronic hepatitis B and they are not immunized against hepatitis A, must get a vaccination against hepatitis A. Hepatitis B is easily preventable by vaccine. Every healthcare provider must be vaccinated against hepatitis B. Every citizen of this city and country must be vaccinated against hepatitis B, because the vaccination gives you a lifelong protection. Those patients who are pregnant and have got hepatitis B, give first dose of hepatitis B vaccine and immunoglobulins within 12 hours of delivery, and then second dose at 1 month, third at 6 months. Even we can give tenofovir in the last trimester to the mother if their viral load is very high, to prevent a vertical transmission. Transplant is the last resort in all advanced liver disease. Maybe it is because of chronic hepatitis, alcoholic hepatitis, autoimmune hepatitis. This is the last resort, or it's because of NASH. Then we are going to talk about delta agent. It is a defective RNA virus. It can cause only hepatitis only in association hepatitis B infection, and specifically presence of surface antigen, because it needs the surface antigen for replication and transmission. It has been acute stage is not seen in cases of hepatitis D. Sometimes it can have a co-infection, so the patient will be having manifestation of hepatitis more mainly because of B. Serology is important, and then if serology is positive, then we can go for a polymerase chain reaction. No specific treatment interferon has been given to these patients. The clearance rate is not very encouraging. Apart from these hepatotoxic viruses, alcohol is the one which can cause hepatitis. Drug-induced hepatitis is quite common, especially those patients who are put on anti-tubercular treatment. Never forget about autoimmune hepatitis, because physician tends to forget about it. This is disease quite common in our community, and it must be kept in mind. Patients who have got vascular diseases may have an ischemic hepatitis. So with this, we are approaching to the end of our today's talk about hepatitis, and this lecture was in continuation to our previous lecture, on which we have talked about the interpretation of liver enzymes. So if you have got any questions, you can just put it on your remarks, and we will try to answer these questions. Before going, let's have a case, a hepatitis panel is ordered for a 27-year-old female as a part of a routine workup for abdominal pain. Result of serological testing negative hepatitis B E antigen and surface antigen, but positive for B surface antigen, and there were immunoglobulins against core antibodies. So this patient has recovered. Patient is in acute infective disease, window period, chronically infected, and patient was never infected.